Good day. My name is Premila Webster, and I'm the co-editor of the Journal of Public Health supplement, Mental Health in India, Bridging the Gap. The supplement brings together some of the research related to mental health in India. In this interview, I talked to one of the authors of the research article, which explores factors influencing care-seeking behavior for mental illness in India. So let me introduce Dr. Anant Jani. He's an Oxford Martin Fellow at the University of Oxford. He works on understanding how health and care systems can efficiently and effectively address social determinants of health, particularly through the use of social prescribing. He has also worked in global health, specifically exploring strategies to tackle malnutrition in children in India and improve access to mental health care in India through the PRIA study. Before this, he worked with Sir Muir Gray in Better Health Value Healthcare and the NHS England Quip Right Care programme. Anand received his undergraduate degrees from Brandeis University and his PhD from Yale University. Thank you for your contribution to the supplement, Dr. Jani. Could you give us a brief background about the Mental Health Act previously and how it led to the 2017 Mental Health Care Act?
Thanks very much, Premila. I think there's probably three key years or dates to keep in mind for the evolution of mental health policy in India. The first was 1982, then 1996, and then 2017, the most recent bill. The first bill, published in 1982, was actually quite groundbreaking because India was the first post-colonial non-white country to actually institute a mental health care policy. So it was very much ahead of the curve back in those days. And it set out very general principles around why mental health needed to be addressed. In 1996, the original National Mental Health Program, the NMHP, which was created in 1982, was revised with a provision to create district mental health programs across India to help actually improve access and care delivery across India's states. The new Mental Health Care Act, which was approved in 2017, the need for it came from the fact that India ratified the UN Charter on Disability Rights. And the old bills, both the 1982 bill and the modified 1996 bills, did not properly account for those, for disability rights. And Keshav Desiraju, who was the Secretary of State for Health and who recently passed away and to whom we have dedicated this issue, was instrumental in actually getting this bill constructed and passed. It was passed in 2017, and some of the policies are beginning to be implemented from it.
Dr. Jani, could you briefly give me a summary of your results and its implication both for further practice and research?
So our project was looking at the factors influencing care-seeking behavior for mental illness in India. We specifically focused on the state of Tamil Nadu, which is where we had a lot of links and connections. And very briefly, what we found were three key factors affecting care-seeking behavior. The first was the views on what causes or constitutes mental illness. The second was stigma and discrimination associated with mental illness. And then the third sort of very broad umbrella factor was the other societal elements that actually influence decision-making, or life elements that influence decision-making. So, for example, the stigmas that people would experience would drive their decision-making behavior, lack of access, knowledge and expectations about what mental health is, or what mental illness is, as well as cost.
Okay. So what sort of implications do you think this would have for further practice and following research?
Well, I think some of our findings, particularly around some of the stigma and cost elements, as well as some of the access elements, I think can really help to inform strategies, operations, and tactics at multiple levels within society. So if we go to the broad elements around stigma, obviously this is a cultural issue. So how do we work with society, civil society organizations, as well as institutions like schools, other charities, temples, mosques, churches, to actually change people's perspectives on what mental illness is and what mental health is? Then you have the other sort of lower layer, the operational layer, which is looking at access and looking more at the logistics of people actually being able to access care. So because so many people live in rural areas and because a lot of the resources are actually positioned in urban areas, there's a big gap, and this is basically a burden of treatment where people have the transport costs are really high, both in terms of financial cost and time. And for many of these individuals who are living, below the poverty line, there's a real opportunity cost to actually seeking care. So building better, safer, more efficient and effective care pathways would be another means by which some of our findings could help to address some of these issues. Transport was one of the key things that we found, and that was linked to cost. And then at a tactical level, is actually sort of working with civil society organizations to raise the awareness about mental illness amongst individuals, so they actually change their care-seeking behavior. If they are feeling a bit down or depressed, that might progress to something more severe, or they feel that it could progress to something more severe, it would be ideal if they actually, seek care before things get too worse.
Any particular challenges you faced when undertaking this research?
Yeah. I'd say probably one of our biggest challenges was getting getting all of the stakeholders aligned and brought together in India. That was probably our biggest challenge, because there's so many players and so many actors, and so us having to find these individuals and choose which, whom we actually worked with, the charities and the charity leaders that we worked with. That was probably one of the biggest challenges that we faced. And
how did you go about overcoming those challenges?
Well, those challenges, I think we would probably have to give, as you well know, having been involved in this project, we'd have to give pretty much all of the credit to our field researchers, Vimita and Naresh, because they just tirelessly, they basically made it happen. And, we'd have conversations with them all the time. And, they were talking about how they'd have to wait outside various buildings in the heat to get various approvals and permissions and things like this. So it wouldn't have happened without them. So it definitely wasn't any of us researchers sitting in leafy Oxford that made it happen. It was definitely down to Vimita and Naresh.
Yes, thank you. What are your thoughts on what the future holds and possible solutions to bridge the gap of mental health services in India?
That's a very interesting question, particularly in the context of COVID, where care needs have increased so dramatically. Not only have care needs increased dramatically, but even on the supply side, meaning the healthcare system, you have exhausted physicians who are working tirelessly to try to meet the demands that are being placed on them. From that contextual perspective, the only thing as a public health person that I could maybe make a suggestion about is to try to focus on the demand side through other strategies. So oftentimes in healthcare, you have the supply side and the demand side. So the supply side is doctors, nurses, hospitals, medications, technologies, diagnostics, etc. And that's where most solutions are focused on the supply side. And given just the constrained system that we already had to begin with before COVID, and now the ultra stressed system that exists in India, I think focusing on the demand side and trying to do more things at a community level, trying to improve mental health from the get-go, so that people don't need to seek care because their well-being and their mental health is at a high level, I think would probably be ideal. And, you know, in order to do that, I think we just need to go back to the basics of social determinants. I know this is a very broad answer, but, you know, if Duncan Selby from Public Health England, you know, what he talks about is, you know, a home, a job, and a friend as 3 critical factors to actually looking after one's well-being. And so I think if we could do more at a societal level in India to actually improve social determinants across the board, improve employment conditions, ensure that everybody has proper nutrition, housing, transport, I think that could help to reduce the demand on healthcare systems. Obviously, this is years in the making, but we have to start somewhere. So we don't know when the next COVID is going to happen.
True. So yes, as you say, it's a big agenda, and also it's going to take a while. But have you any thoughts of possible first steps that, at least in small areas, that could get this going?
I think one of the challenges or limitations that they found from the 1996 bill, where they proposed a district mental health programs, was the actual implementation of the policies themselves. It was very heterogeneous. So Tamil Nadu, I think only 50% of the districts actually had a district mental health program. I think it's a very simple step. Just looking at the policies that we currently have, which are well designed to a large extent, and trying to ensure that they're operationalized efficiently and effectively, I think would be an easy-ish first step. Yeah.
I mean, as you said, the newish bill has brought in a whole, thanks to Keshav Desaraju and his absolutely extraordinary efforts, has brought in really good policies, but it's about implementation and where it's implemented and how it's implemented. You got any thoughts about, you know, how that could be sort of make sure it's at least the starting of implementation, and any things that would help towards that?
I suppose, I mean, that those decisions have to be made at a state and district level. So I think as, you know, a very simple starting point, looking at trying to align interests as well as, you know, learning and sharing between different entities is for every state in India to have one person responsible for the operationalization of the mental health policy. So very simple step. And then for all of the individuals from across India's states to actually have meetings together. Maybe they're already doing this. This is, you know, sort of ignorance on my part. I haven't done enough homework to know whether or not they are actually doing this, but that would be, from my perspective, a first step. And the other would be to see, rather than focusing on the negative and the fact that there are, you know, 50% of districts in Tamil Nadu don't have DMHPs. If we took a positive deviance approach to look at the districts that do have DMHPs and ask why do they have DMHPs, and then to collate a set of how-tos or best practices that we could then disseminate not only within Tamil Nadu, but across other states as well, because other states have DMHPs as well. So collecting that best practice, doing a bit of homework, and then trying to use these homegrown solutions. If it worked in half of Tamil Nadu's districts, whatever strategies were used, then it's likely that it'll work in the other half. And if there are other DMHPs across India in the different states, then maybe identifying the best practice for those context-specific factors that dictate whether they can run effectively and efficiently, I think might help.
Yes, no, that's good sort of solution, possible solution. And by you mean district mental health when you say mental health areas, yeah. What do you think is the role of, because as you may have seen in the supplement, we've got articles from sort of charities who run, like the Banyan and Scarf. What do you think is the role of the charities and other agencies in sort of contributing to this and strengthening this?
Yeah. There's a couple of different dimensions to my answer for this. One is they are absolutely essential currently. I think, the Banyan is a great example of this. They deliver services for people who can't access services elsewhere or might feel stigmatized going to a hospital to access care. So they are absolutely essential right now. That said, I think it's a failure of the system that they need to be absolutely essential. I think it's, wonderful, and I think it's a beautiful display of giving, that they are there and providing these services, and they work tirelessly to do so. But the fact that they're the only ones delivering these services, there's something fundamentally wrong with that.
That's true. And so it's about getting them working together with the government agencies and, as you say, learning from examples of why and how they're getting these things to work, and learning from that would be very good. Any final thoughts?
My final thought again would, be to go back to the supply side, demand side thing. I think we need to get the basics right, and India has struggled with this for decades, ever since independence. Housing, transport, jobs, education, nutrition. If we were able to tackle these things, I think a lot of the disease burden would disappear in India. It would be a much healthier and more prosperous country. So I would say that if we were to put our money somewhere, it should be there.
Thank you very much, Dr. Cowling. Thank you.
Thanks.